Structure and Functions of the Body, a Handbook of Anatomy and Physiology for nurses and others desiring a practical knowledge of the subject, by Annette Fisk, AM, graduate of the Waltham Training School for Nurses. Copyright 1911 by W.B. Saunders Company, printed in America, and prepared for digital distribution by Project Gutenberg, read by Christopher Robert Neal. Chapter 11, The Pelvis and the Genital Organs. Contents: the pelvis, the male generative organs, the prostate gland, the testes, the penis, the female generative organs, the ovaries, the fallopian tubes, the uterus, the vagina, the external genitalia in the female, the vulva, the mons veneris, the labia majora, the labia minora, the clitoris, the meatus urinaris, the hymen, the fourchette, the perineal body, the perineum. Chapter 11, The Pelvis and the Genital Organs. The pelvis. Before taking up the pelvic organs, the pelvis itself should be described. The name pelvis has been given to the bony ring which is interposed between the spine and the femurs on account of its resemblance to a basin. At the back of this basin or pelvis are the sacrum and coccyx, already described in connection with the back, and at the sides and meeting in the median line in front are the two ossa innominata, or nameless bones, so called on account of their peculiar and indescribable shape. At birth, each innominatum is made up of three bones: the ilium, ischium, and pubes, or pubis. But about the age of puberty, the three become welded into one. At their point of junction is the cavity of the acetabulum for articulation with the head of the femur or thigh bone. The upper expanded portion of the os innominatum is the ilium, whose upper body. The upper expanded portion of the os innominatum is the ilium, whose upper border is known as the crest, and which has two spinous processes, front and back, a superior and an inferior, the superior spine being in each case the larger. The spines, especially the anterior superior spines and the crest, give attachment to many muscles, and to the outer surface of the bone, the gluteal muscles are attached. The anterior superior spine is also important in making measurements to ascertain whether both legs are of equal length. Below the ilium posteriorly is the body of the ischium, which has on its lower edge a tuberosity, the prominent bone on which one sits. Near the upper edge is the spine of the ischium, between which and the posterior inferior spine of the ilium is the greater sacrosciatic notch for the passage of vessels and nerves, including the sciatic nerves, From the tuberosity, the ramus extends forward below the obturator foramen, a large opening between the ischium and the pubis, also for the passage of vessels and nerves to meet the pubis. The last and smallest of the three bones which go to make up the os innominatum, the anterior surface of each pubis presents a crest, ending externally in a spine, and the two pubic bones join in front in the symphysis pubis. The bone gets its name from the growth of pubic hairs over this region at puberty. Anteriorly, the ossa innominata support the external organs of generation, while within are the internal organs of generation. On the inner surface of the ilium, slightly above the level of the acetabulum, is the iliopectineal line, above which lie the iliac fossae, a plane drawn through the prominence of the sacrum, the iliopectineal lines, and the upper margins of the symphysis pubis serves to divide the upper or false pelvis from the lower or true pelvis. The false pelvis, which is the larger, serves to support the intestines and to take part of the weight from the abdominal walls, while the true pelvis, being more surrounded by bone and so capable of affording more protection, guards the internal organs of generation. The lower circumference of the pelvis is known as the outlet. In the female, the bones are lighter, the sacrum less curved, and the diameters greater than in the male. On the whole, the pelvic bones are well covered in with muscles. The anterior superior spine, however, is easily felt in front, and the whole crest can be felt back to the posterior superior spine. The tuberosity of the ischium also can be felt, especially when the thigh is flexed, for it is largely uncovered of muscles. The spine of the os pubis can always be felt on a level with the great trochanter, and the relation of its position to that of a hernia shows whether the rupture is above or below Popart's ligament, that is, whether it is inguinal or femoral. Occasionally, there is lack of development of the pubic bones for 2 or 3 inches and the bladder is exposed. Fracture of the pelvis may occur, perhaps with injury to the viscera. The acetabulum may be fractured or the sacrum bone, with injury to the sacral plexus of nervus. The acetabulum may be fractured or the sacrum broken, with injury to the sacral plexus of nerves, causing paralysis of the lower extremities and of the sphincters, with resultant involuntary passage of urine and feces, and in childbirth the coccyx is often broken. In rickets, there may be great deformity of the pelvis, causing trouble in childbirth later in life. Osteomalacia is a disease of adults in which the bones are soft and the weight pushes the promontory of the sacrum forward and approximates the sides of the pelvis. The male generative organs. The male generative organs consist of the prostate gland, testes, and penis. The prostate gland is shaped like a small horse chestnut and is composed of numerous glands from which come a dozen or more excretory ducts. It surrounds the neck of the bladder and the beginning of the urethra and is next to the rectum, through which an examination may be made to determine its size, for it often enlarges in elderly men. The frequent passage of urine in small amounts being a symptom of enlarged prostate. The procreating glands, which secrete the spermatozoa or semen, are two in number. The testes are testicles and are homologous to the ovaries in the female. They are ovoid in form and are suspended by the spermatic cords in a sac, the scrotum, back of the penis. During early fetal life, they are in the back of the abdomen near the kidneys, but before birth they descend along the inguinal canals into the scrotum. The excretory duct of the testes is called the Vas Deferens. It passes up by the spermatic cord through the inguinal canal into the pelvis to the base of the bladder, and at the base of the prostate joins the duct of the vesicula seminalis to form the ejaculatory duct. The two vesiculae seminales are small receptacles for the semen lying in contact with the base of the bladder and secrete a fluid with which they dilute the semen. The ejaculatory duct terminates near the prostate in the urethra by a slit-like orifice on each side, the spermatozoa being finally excreted through the urethra. The penis is the external organ of generation in the male and is attached to the pubes and the anterior part of the ischium. It is composed of erectile tissue and encloses the urethra. The meatus urinaris or meatus urinarius, appearing at its end as a vertical slit. Toward the end of the skin of the penis, toward the end, the skin of the penis is loose and is prolonged forward in what is known as the prepuce or foreskin. It is this that is clipped away in circumcision. The female generative organs. The female generative organs include the ovaries, fallopian tubes, uterus, vagina, and the external genitalia or vulva. The ovaries, which are homologous to the testes in the male, are two flattened oval bodies, grayish pink in color, suspended from the lateral or broad ligaments which fasten the uterus to the walls of the pelvis. They are 1¼ inches long, 3/4 of an inch wide, and ½ inch thick, and are attached at the upper end to one of the fimbriae of the fallopian tubes. They consist of numerous Graafian follicles embedded in a fibrous stroma, each follicle containing an ovum about 1/125th inch in diameter and just visible to the naked eye. When a follicle ruptures and discharges an ovum, An irregular yellow spot, the corpus luteum, appears at the point of rupture. After ordinary menstruation, it is known as the false corpus luteum, and after conception as the true one, this one being larger and lasting longer. The fallopian tubes are the oviducts and convey the ova from the ovaries to the uterus. They are 4 inches long and lie between the layers of the broad ligaments, opening into the uterus by an orifice the size of a bristle, while the end next to the ovary spreads out trumpet-like and is edged with fimbriae as with a fringe, the fimbriated extremity. There are 3 coats: a serous coat, which is continuous with the peritoneum, a muscular coat, and within a mucus coat covered with cilia, continuous with the mucous membrane of the uterus. One fimbria is attached to the ovary, and as the ovum is given off, it finds its way into the tube and thence into the uterus. The uterus is a pear-shaped organ about 3 inches long, 3 inches broad, and 1 inch thick, situated in the pelvic cavity between the rectum and the bladder. The wide part or fundus is above and the narrow neck or cervix below, lying partly within the vagina. The whole is held in by ligaments. These include the broad ligaments. Which extend from the sides of the uterus to the lateral walls of the pelvis, and the round ligaments, 2 muscular cords about 4 inches long, which pass out through the abdominal ring into the inguinal canal, and so to the mons veneris and labia, thus corresponding to the spermatic cords in the male. The cavity of the body of the uterus is small and flattened, and opens into the cervix by the internal os uteri, the external os being at the opening of the cervix into the vagina. There are 3 coats: a serous coat derived from the peritoneum, a muscular coat of unstripped fibers which forms the bulk of the whole organ, and a mucus coat covered with ciliated epithelium. The uterus is always enlarged during menstruation and is enormously enlarged in pregnancy. It receives the fecundated ovum, retains and supports it during the development of the fetus, and is the chief agent of expulsion. In tubal or extrauterine pregnancy, the ovum becomes attached in the tube instead of in the uterus, and develops there, rupturing the tube and causing serious hemorrhage. The passage from the cervix out of the body is the vagina, a membranous canal, curved upward and backward to conform to the axis of the pelvis, and attached above to the cervix. Ordinarily, the sides are in contact. The arteries of the internal organs of generation are the uterine from, the internal iliac, and the ovarian from, the aorta in the female, the pundic branches of the internal iliac, and the spermatic from the aorta in the male. The nerves are largely from the sympathetic system. Abscess formation occurs frequently in the tubes, and gonorrheal infection may spread up the vagina and through the uterus to the tubes, and even to the abdominal cavity itself. The tubes may also be tubercular. Salpingo Gectomy, or removal of the tubes, is the commonest operation after that for appendicitis. Cancer of the uterus may necessitate panhysterectomy or removal of the uterus and all its appendages. The external genitalia in the female, as in the male, are situated over the pubic arch. They are known as the vulva and include the mons veneris, the labia majora and minora, the vaginal orifice, the clitoris, and the meatus urinarius. The mons veneris is a rounded eminence composed of fatty tissue which surmounts the pubic bones and is covered with hair at puberty. From it, two prominent longitudinal folds of skin, covered with hair on the outside, the labia majora, extend backward, forming the lateral boundaries of the vulva. Within these labia again are two thin cutaneous folds, the labia minora or nymphae, which run back from the clitoris for about 1.5 inches and enclose the vaginal orifice. The clitoris corresponds to the penis and is just above the upper part of the labia minora. Between it and the vagina is the meatus urinarius. The orifice of the vagina is partly closed in the orifice of the vagina is partly closed in the virgin by the hymen, a third fold of the mucous membrane which occasionally closes it completely, imperforate hymen. The fourchette is a small transverse fold of skin at the junction of the labia minora. Posteriorly, between the vagina and the rectum, is the perineal body, a somewhat triangular structure made up of many small muscles. Its surface is known as the perineum. It is frequently torn wholly or in part during childbirth and has to be sewed up. Chapter 12, the Upper Extremities. Contents: the shoulder girdle, the clavicle, the scapula, shoulder muscles, the humerus, upper arm muscles, the ulna, the radius, the wrist, the hand, metacarpals, phalanges, muscles of the forearm, muscles of the hand, joints of the upper extremity, blood supply of the upper extremity, nerves of the upper extremity. Chapter 12, the Upper Extremities. The upper extremities include the shoulders, arms, forearms, wrists, and hands and contain each 32 bones. The bones of the two shoulders taken together are called the shoulder girdle and consist of the two clavicles or collarbones and the two scapulae or shoulder blades, which together make an almost complete girdle of the shoulders. The clavicle is a long, slender bone extending almost horizontally from the sternum to the scapula and can be felt for its whole length in the living. For the inner two-thirds, it is convex anteriorly, for the outer third, concave. In woman, it is generally less curved, smoother, and more slender than in man. And as bone is rough when the muscle attached, and as bone is rough when the muscles attached are powerful, the right clavicle, being used more, is generally rougher and thicker than the left. Among the muscles attached are the large neck muscle, the cleodomastoid, whose tendons form the presternal, presternal notch, the trapezius, the pectoralis major, and the deltoid. Being slender and superficial, the clavicle is most frequently broken of any bone in the body, generally by indirect violence, as by falling with the hand out, though old people in such a case are apt to get colasis fracture at the wrist. The bone generally gives way at the juncture of the outer and middle thirds, with displacement of the parts inward, so that the fracture is seldom compound. Since, however, the main vessels of the upper arm, with their nerves, lie beneath the clavicle, there is danger of their being punctured. Such serious injury is guarded against by the presence of the subclavius muscle. The clavicle is occasionally removed for sarcoma. The scapula or shoulder blade, so called for its shape, is a large, flat, triangular bone with a prominent ridge, the spine, crossing its dorsum or posterior surface near its upper edge. It extends from the second to the seventh rib, with its posterior margin parallel to and about 1 inch from the dorsal vertebrae. The head, in which is situated the glenoid cavity for articulation with the humerus or upper arm bone, is surrounded by a slight constriction, the neck. Above it projects the coracoid process, so called from its fancied resemblance to a crow's neck. Again, above it projects the coracoid process, so called from its fancied resemblance to a crow's beak. This can usually be felt about 1 inch from the juncture of the outer and middle thirds of the clavicle, and from it arises the short head of the biceps and the Coraco Brachialis muscle. The Acromion process at the end of the spine extends out beyond the glenoid cavity posteriorly and affords attachment to the deltoid and trapezius muscles. It forms the summit of the shoulder. Numerous other muscles are attached to the surface of the scapula, the only parts which are truly subcutaneous being the whole length of the spine and the acromion process, though the lower angle and the coracoid process can generally be felt. The muscles bulge so much that the spine in the living appears as a slight depression extending back almost to the vertebrae. The large number of the muscles on the shoulder and arm is due to the great flexibility and strength required for the various usage to which the arms are put. Shoulder muscles. The most important shoulder muscle is the deltoid, a large triangular muscle which surrounds and projects and protects the shoulder joint and gives the shoulder its rounded form. It rises from the outer third of the clavicle, from the acromion process, and from the whole length of the spine to the scapula, and is inserted by a tendon into a rough prominence on the middle of the outer side of the humerus. It serves to raise the arm and to draw it somewhat forward or back. According to the anterior or posterior fibers are used. It serves to raise the arm and to draw it somewhat forward or back, according as the anterior or posterior fibers are used. The pectoralis major rises from the inner half of the clavicle, the front of the sternum, and the cartilages of the two ribs and its fibers converge to form a fan-shaped muscle, which is inserted by a flat tendon into the edge of the bicipital groove on the humerus. It draws the arm forward and inward and helps considerably in forced inspiration. The serratus magnus rises from the outer surface and upper border of the 8 upper ribs and from the aponeurosis, covering the upper intercostal spaces, and is inserted along the whole length of the posterior border of the scapula. It carries the scapula forward and is used in pushing. The scapula is seldom broken because it is quite movable and is covered with large muscles, and because it lies on the chest, which serves as an elastic cushion. The Acromion process is the part most frequently broken, and occasionally the neck is fractured. Tumors occur and may necessitate the amputation of the whole upper extremity. The humerus. The bone of the upper arm, the humerus, is the largest bone in the upper extremity and articulates with the scapula above and with the ulna and radius below. At its upper end are the head and the anatomical neck, with the greater tuberosity external to and the lesser tuberosity in front of them. The constriction of the surgical neck is below the tuberosities, and extending from between them downward and inward along the upper third of the bone is the bicipital groove from the long head of the biceps. Though round above, below the shaft becomes flattened from before backward and curves slightly forward, terminating in the internal and external condyles, from the former of which the flexors and the round pronator arise, and from the latter the extensors and supinators. From the external condyle also there projects in front the radial head or capitellum for articulation with the radius. Internally to the capitellum, in front and in a corresponding position on the back of the bone, are the trochlear surfaces for articulation with the ulna, there being a depression in front called the coronoid fossa for the reception of the coronoid process of the ulna, inflexion of the forearm, and another depression behind the olecranon fossa to receive the tip of the olecranon process during extension. On the lower half of the humerus at the back is the spinal groove for the musculospiral nerve and the superior profunda artery, while the ulnar nerve runs in a groove back of the internal condyle. The humerus is almost completely covered with muscles, the only part that is subcutaneous being a small portion of the external and internal condyles. The head can be felt under the muscles, and the greater tuberosity forms the point of the shoulder. When the arm is at the side, the biceps appear at the front and inner side, and the brachialis anticus on either side below, while the back of the arm, with its largest swelling above, is the triceps. Upper arm muscles. The biceps is the most important arm muscle. It rises by a short head from the coracoid process of the scapula and by a long head from a tubercle on the upper margin of the glenoid cavity, the tendon arching over the head of the humerus and descending in the bicipital groove. It is inserted into the back of the tuberosity of the radius and by a broad aponeurosis into the fascia of the forearm. It flexes and supinates the forearm and renders the fascia tense. Its inner border forms a guide in tying the brachial artery, as this artery runs along its inner side. The brachialis anticus rises from the lower half of the outer and inner surfaces of the humerus and is inserted into the coronoid process of the ulna, thus covering and projecting the elbow joint anteriorly. It is a flexor of the forearm, another smaller muscle on the anterior arm, which also aids in flexion, is the Coraco Brachialis, which extends from the coracoid process of the scapula to the middle of the inner surface of the humerus, extending the entire length of the posterior surface of the humerus, is the triceps, similar to the quadriceps extensor in the thigh and direct antagonist to the biceps and brachialis anticus muscles. It rises by a long head from below the glenoid fossa, by the external head from the upper third of the posterior surface of the humerus, and by the internal head from the middle and lower thirds of the posterior surface. It is inserted in the olecranon process of the ulna and serves to extend the forearm and arm. The humerus is more often fractured by muscular action than any other bone. Usually the fracture occurs in the lower half of the bone, and sometimes the musculospiral nerve is involved. There is a great tendency to non-union, probably due to interposition of soft parts. Sometimes the break is across and down between the condyles, T-fracture. Involvement of the elbow joint is more serious than fracture of the humerus alone. Sarcoma of the humerus does occur and may require the removal of the clavicle and scapula as well as of the arm bone itself. An amputation of the humerus in children, a long skin flap is left to allow the growth of the bone, as it is liable to grow again. The ulna in the forearm there are two bones, the ulna and the radius, of which the former is the longer. The ulna is on the inner side of the forearm, and its upper end forms the greater part of the articulation, with the humerus, as most of the articulation at the wrist is formed by the radius and the interarticular fibrocartilage. The head of the ulna is at the lower extremity of the bone and articulates on the outer side with the radius and below from the triangular fibrocartilage. From its inner side projects the styloid process. The olecranon process forms the upper extremity and presents anteriorly an articular surface. The greater sigmoid cavity for articulation with the trochlea of the humerus, where it fits into the olecranon fossa during extension. The same articulating surface also covers the coronoid process, a smaller projection below and in front of the olecranon, which fits into the coronoid fossa during flexion. Continuous with the greater sigmoid cavity of the outer side is the lesser sigmoid cavity for articulation with the head of the radius. Under the triceps tendon, which is inserted into the olecranon, is a bursa or sac of synovial membrane, such as occurs in parts where much force is brought to bear. The radius, or spoke of the wheel, is on the outer side of the forearm and gets its name from the way it turns upon the ulna and pronation. The shaft is larger below than above and is slightly curved longitudinally for greater strength. The upper extremity or head is small and has a slightly concave upper surface for articulation with the radial head of the humerus. It articulates by its side with the lesser sigmoid cavity and is bound to the ulna by the orbicular ligament, which runs over a smooth articular, which runs over it articulates by its side with the lesser sigmoid cavity and is bound to the ulna by the orbicular ligament, which runs over a smooth articular surface. Below the head is the constriction of the neck with the tuberosity for the biceps tendon to the inner side below. The lower extremity is large and forms the chief part of the wrist joint, articulating with the semilunar and the scaphoid bones of the wrist. From the lower extremity, the strong conical styloid process projects externally. In the living, the olecranon process of the ulna is always felt at the elbow, and the posterior border of the ulna forms the prominent ridge down the forearm, leading to the styloid process. The head of the radius is felt just below the external condyle and often makes a dimple in the muscles of the forearm. The rest of its upper half is concealed with muscles, but the lower half is easily felt as there are only tendons over it. The styloid process is felt externally. Normally, that of the radius is a little lower than that of the ulna, so that in cases of fracture, the relative position is of considerable importance as showing the amount of deformity. The two forearm bones are more frequently broken together than separately and generally by direct violence, the lower fragment being usually drawn up by the action of the flexor and extensor muscles and producing a swelling of the palmar surface of the forearm. Indirect violence usually causes fracture of the radius only. In both cases, but especially in fracture of both bones, there is a tendency for membrane to get between the fragments, so the arm is put in splints with the hand midway between pronation and supination in order to separate the bones as far as possible. Care must be taken not to have the bandage too tight, or gangrene of the fingers may result. In most fractures of the arm, it is put up bent, but in fracture of the olecranon, it is put up fully extended, as the fragment is sure otherwise to be displaced by the pull of the triceps. In fact, the olecranon is sometimes fractured by the muscular force of the triceps, though usually its fracture, which is frequent, is due to direct violence. The ulna is also often fractured in the middle by direct violence, or the styloid process may be broken. Fracture of the neck or shaft of the radius is very common, the most important arm fracture being that of the lower end of the radius or collis fracture. This and the corresponding fracture in the leg, Potts fracture, are two of the commonest fractures. In dislocation of the wrist, the normal relation of the two styloid processes remains unchanged, but in collisis fracture, the lower fragment often projects on the back of the hand, making a typical deformity called the silver fork deformity. The bones of the wrist and hand had best be described before the forearm muscles are taken up, as the muscles of the forearm are distributed largely to the fingers. The wrist. The wrist, or carpus, is made up of 8 bones arranged in 2 rows of 4 each. In the first row are the scaphoid and semilunar bones, on the outer side articulating with the radius, the cuneiform articulating with the fibrocartilage of the wrist joint, and the pisiform. In the second row and corresponding positions are the trapezium, trapezoid, os magnum, the unciform. The eminence felt on the radial side of the wrist is the protuberance of the scaphoid, while the pisiform is generally felt on the ulnar side. The hand. The hand contains 19 bones, 5 metacarpal bones, 1 for each finger and the thumb, whose bases articulate with the lower row of wrist bones, and 14 phalanges, 3 for each finger and 2 for the thumb, of which the first row articulate with the metacarpal bones. They are all long bones and are slightly concave anteriorly. When the hand is flexed, it is the heads of the metacarpal bones, not the bases of the phalanges, that are so prominent, that the head of the third metacarpal being most prominent. The metacarpals are seldom fractured, though bad fractures occur. The metacarpals are seldom fractured, though bad fractures occasionally occur. In comminuted fracture, nothing can be done but remove the bone. The periosteum is left, the bone will grow again. 2 diseases sometimes affect the metacarpals and the phalanges, tuberculosis and syphilis. Both cause swelling of the bones. Muscles of the forearm. The chief groups of muscles on the forearm are the flexors and pronators on the anterior surface, and the extensors and supinators on the posterior surface. In general, the flexors and pronators take their origin from on or around the internal condyle, while the extensors and supinators arise on or around the external condyle, where not otherwise stated, it will be understood that such is their origin. In a general way, they may be grouped as follows: anterior surface, flexors of wrist, which are the flexor carpi radialis, flexor carpi ulnaris, palmaris longus, then the flexors of fingers, which are the flexor sublimis digitorum, and the flexor profundus digitorum, then the flexor of thumbs, which is the flexor longus pollicis, then the pronators of hand, Pronator radii teres and Pronator quadratus. The posterior surface, we have the extensor or forearm called anconeus, then the extensors of wrists, including extensor carpi radialis long, extensor carpi radialis breve, and extensor carpi unaris. Then the extensors of thumb, extensor ossis metacarpi, extensor primi interno nodi, extensor secundi internodi. Extensor of fingers, extensor communis digitor, extensor of index finger, extensor indicis, extensor of little finger, extensus minimi digiti, supinator of hand, supinator longus, supinator brevis. Of the flexors of the wrists, the flexor carpi radialis is inserted into the base of the index and usually of the third metacarpal bone, the flexor carpi ulnaris, into the fifth metacarpal, the pisiform, and the unciform bones. While the palmaris longus goes to the anterior annular ligament of the wrist and the palmar fascia of the hand, the flexor sublimis digitorum is inserted by four tendons into the second phalanges of the fingers, while the flexor profundus digitorum arises from the upper part of the ulna and is inserted into the last phalanges of the fingers. The flexor of the thumb arises from the middle of the radius and is inserted into the last phalanx of the thumb. Which joint is flexed by a muscle depends upon the origin of the insertion of the muscle, all those included between being affected, thus the flexor sublimus digitorum, which has its origin in part at least from the condyle and is inserted in the second phalanges of the fingers, flexes the forearm, wrist, and all the finger joints but the last, while the flexor profundus digitorum, arising from the ulna, though it flexes the wrist and fingers, has no power of flexing the forearm. The Pronator Quadratus, besides arising from the supracondylar ridge, rises from the coronoid process of the ulna. It is inserted into the middle of the outer surface of the radius and serves to pronate the forearm. The other pronator, the Pronator Quadratus, is a small quadrilateral muscle extending transversely across the radius and ulna just above the carpal extremities. It rises from the anterior surface of the ulna and is inserted into the anterior external border of the radius. On the back of the forearm, the anconius serves to extend the forearm only, being inserted into the upper part of the posterior surface of the ulna. The extensors of the wrist are inserted into the bases of the various metacarpal bones and have some power to extend the forearm as well as the wrist. The extensors of the thumb, as their name implies, go one to the metacarpal bone and one to each of the phalanges, the longest one extending the whole thumb, the others only a part. They rise from the ulna and radius, not the condyle. The extensor cuminus digitorum goes to all the phalanges of all the fingers. The extensor minimi digiti to those of the little finger only, and the extensor indicis to those of the indexed finger. The last two arising short of the condyle. Of the supinators, the longer one is inserted into the styloid process of the radius, while the shorter one, the supinator brevis, is inserted into the upper part of the same bone, both thus serving to turn the radius of the ulna. Where the tendons of the various muscles pass over the wrist, both front and back, they are covered with a synovial sheath and are held down by a broad ligament, which some of them perforate, the annular ligament, the strong fibrous band, and the anterior annular ligament arches over the carpal bones in front. Beneath it pass the median nerve and the tendons of the flexors of the fingers and thumb. The posterior annular ligament is of less importance. The deep palmar fascia forms a sheath for the muscles of the hand. In carpenters, there sometimes occurs, due Poitrens contraction of the palmar fascia, which draws the fingers up. As operation is not always successful, it is quite a serious matter. The muscles of the hand itself include various abductor, adductor, and short flexor muscles of the thumb and little finger. They also extend between the metacarpal bones, the lumbricales, four small muscles that aid the deep flexor muscles, likewise seven enterosae, of which four are dorsal and three palmar. The dorsal enterosae arise by two heads from the adjacent side of the dorsal enterosae arise by two heads from the adjacent sides of the metacarpal bones and are inserted into the bases of the first phalanges, thus abducting the fingers, while the palmar enterosae arising from the palmar surface of the second, fourth, and fifth metacarpals are inserted into the three corresponding first phalanges and adduct the fingers toward an imaginary line through the middle finger. Blood supply of the upper extremity. The blood supply of the upper extremity comes through the subclavian artery, which on the right springs from the innominate artery and on the left from the aortic arch. It remains one trunk as far as the elbow, though different names have been given to different parts. Thus, as it passes over the lower border of the first rib, it becomes the axillary, and at the lower border of the axilla, where it starts down the arm, the brachial. At the elbow, it divides into the ulnar and radial arteries. In its upper part, the brachial artery lies internal to the humerus, but below it is the front of the bone. The radial runs in a line from the middle of the elbow anteriorly to the inner side of the styloid process of the radius and is much exposed to injury in the lower third of its course, as when the hand is thrust through glass. On it, at the wrist, the pulse is counted. It is much smaller than the ulnar and winds around. It is much smaller than the ulnar and winds around the outer side of the thumb to the palm, where, with the deep branch from the ulnar, it forms a deep palmar arch. The ulnar artery passes obliquely inward to the middle of the forearm and thence along its ulnar border to the palm of the hand, where it divides into the deep branch and the superficial palmar arch, which supplies the four digital arteries. From the axillary artery, branches go to the chest wall and shoulder, the most important being the two circumflex arteries to the deltoid. The brachial has only two branches of any importance, the superior and inferior profunda, both of the upper arm, of course. In case of hemorrhage, compression can frequently be applied with the fingers where the subclavian crosses the rib or in the axilla where the artery can be pressed up against the humerus. Nerves. The nerve supply of the shoulder comes chiefly from the anterior and posterior thoracic, the suprascapular, and the circumflex, these last going to the deltoid. The biceps is supplied by the musculocutaneous, the triceps by the musculospiral, and the brachialis anticus by both. Most of the flexor and pronator muscles are supplied by the median, while the posterior interosseous and the musculospinal nerves go to the extensors and supinators. The ulnar nerve supplies the hand largely. End of chapter 12. Chapter 13, the final chapter, the lower extremities. the femur, thigh muscles, the patella, joints of the lower extremity, the tibia, the fibula, the ankle, the foot, metatarsals, phalanges, muscles of the leg, the blood supply of the lower extremity, nerves of the lower extremity. Chapter 13, the lower extremities. The lower extremities resemble the upper very closely in the arrangement of the bones, muscles, arteries, and nerves, though modification occurs due to the difference in function of the lower limbs. There is one long bone in the upper part or thigh, the femur, and two in the lower part or leg, the tibia and fibula, while over the knee joint is the patella or kneecap. The ankle has 7 bones and the foot 19 like the hand. The femur. The femur is the longest bone in the body, being about 1/4 the height of the person. It inclines toward its fellow at the knee in order to bring the knee joints near the center of gravity in walking, the amount of inclination varying with the width of the hips and the height of the person. On account of the greater width of hip, the tendency to knock knee is greater in women than in men. The shaft of the femur is enlarged at the extremities and is slightly curved forward, the concavity being strengthened at the back by the longitudinal ridge, the linea aspera, along part of which the gluteus maximus muscle is attached. The head, which is covered with cartilage, except for an oval depression for the attachment of the ligamentum teres, one of the ligaments of the hip joint, and which articulates with the hollow of the acetabulum, is the os innominatum, projects considerably upward, inward, and forward from the shaft, the neck varying much in length and angle. It is generally more horizontal in women than in men, and in rickets the great weight on the softened bone tends to press the head down, causing the deformity known as coxa vara, in which the neck is almost horizontal, extending upward, outward, and backward from the shaft at the base of the neck, about 3/4 of an inch lower than the head, and about on a level with the acetabulum, and the spine of the os pubis is the greater trochanter. This large irregular prominence and the smaller one of the lesser trochanter, which is at the lower part of the base of the neck posteriorly, are for the attachment of muscles and to assist in rotating the bone. The lower extremity of the femur is larger than the upper and is flat from before backward. Between its two large eminences, the external and internal condyles, is a smooth depression. In front the trochlear, in front the trochlear surface for articulation with the patella. The external condyle is more prominent in front, the internal inferiorly, the latter being the longer of the two by about half an inch. The epiphysis at the lower end of the femur is the only one in which ossification has begun at birth. Therefore, if ossification is found there, the child is known to have arrived at full term. So many large muscles are attached to the femur that the shaft cannot be detected in the living unless the person is very thin and poorly developed. The outer surface of the greater trochanter, however, and the condyles can be felt. A string stretched from the anterior superior spine of the ilium to the tuberosity of the ischium passes in the middle just over the upper edge of the greater trochanter. The line thus drawn is known as Nelaton's line and is of considerable importance in many conditions of the hip. Thus, if the hip is dislocated, the trochanter will be thrown above Nelaton's line, and in osteomalacia, the pelvis sinks and the trochanter is again above the line. Thigh muscles. Of the thigh muscles, only a few need to be mentioned. One large muscle is the psoas magnus, which has its origin on the front of the last dorsal, and all the lumbar vertebrae passes down across the brim of the pelvis and under Popart's ligament, gradually diminishing in size, and terminates in a tendon that is inserted into the lesser trochanter. It serves to flex the thigh of the pelvis. It serves to flex the thigh of the pelvis and to rotate it outward. The psoas parvus, or psoas parvus, rises from the last dorsal and the first lumbar vertebrae and does not go out of the pelvis. The sartorius or talar muscle is flat and ribbon-like and is the longest muscle in the body. It rises from the anterior superior spine of the ilium and is inserted into the upper inner surface of the shaft of the tibia. By it, the legs are crossed. It also forms the outer side of an important landmark, Scarpa's triangle, whose base is formed by Popart's ligament, and the inner side by the adductor magnus muscle, which passes from the ramus of the os pubis and the tuberosity of the ischium to the linea aspera. The femoral artery bisects the triangle and runs into its apex. The bulk of the anterior portion of the thigh is formed by the quadriceps extensor, which is really made up of four muscles: the rectus femoris, whose origin is on the anterior inferior iliac spine and above the acetabulum; the vastus externus, which comes from the greater trochanter in the upper linea aspera; and the vastus internus and crureus, which rise from the neck of the femur and the linea aspera. It is inserted into the tubercle of the tibia by the ligamentum patellae, in which the patella lies. Its action is to extend the leg. At the back and forming the buttocks are the three glutei muscles, the gluteus maximus, medius, and minimus. All these rise from the outer side of the ilium and have their insertion or all these rise from the outer side of the ilium and have their insertion on or about the great trochanter. They serve to hold the trunk erect and to extend, abduct, and rotate the thigh. Lower down and forming the back of the thigh are the biceps and the semitendon. Lower down and forming the back of the thigh are the biceps and the semitendinosus and semimembranosus muscles. The biceps rises by two heads from the tuberosity of the ischium and the linea aspera and is inserted into the head of the fibula. It is on the outer side of the thigh and its tendon, which embraces the external lateral ligament of the knee joint, forms the outer hamstring on the inner side of the semitendinosus and the semimembranosus muscles. These rise from the tuberosity of the ischium and are inserted, the one into the upper inner surface of the shaft of the tibia and the other into the internal tuberosity of the tibia. Their tendons form the inner hamstring. Like the bicep, they serve to extend the thigh and flex the leg on the thigh, but where the biceps rotates the leg out, they, being attached to the inner side of the leg bones, rotate it in. The patella, or small pan, is a flat, somewhat triangular bone developed in the quadriceps extensor tendon. Four muscles are attached to it, as well as the ligamentum patellae, which holds it to the tibia and gives increased leverage by making the quadriceps extensor work at a greater angle. It articulates with the condyles and serves to protect the joints. One bursa, the prepatellar bursa, separates it from the skin, and another, surrounded by the adipose tissue, from the head of the tibia. The external surface can be seen and felt on the front of the knee, and the bone can be moved from side to side when the leg is straight. Joints of the lower extremity. The hip joint is a ball and socket joint, but it is not so freely movable as the shoulder joint. The head of the femur being held in the acetabulum by many strong ligaments, of which the most important is the capsular ligament. The knee joint is largely a hinge joint, but in some positions it has some rotation. It is formed by condyles of the femur, the head of the tibia, the patella, and has 14 ligaments, including the ligamentum patellae and the crucial ligaments. Its synovial sac is the largest found in any joint. Two semilunar cartilages placed on the head of the tibia serve to deepen the socket for the condyles, changing somewhat in shape and thickness as the joint moves. The the interval between the thigh and the leg bones can be felt at the knee. When the leg is extended, the juncture of the bones is slightly above the patella, while in flexion, a knife passed below the apex of the patella will pass into the joint. Congenital dislocation of the hip occurs. Separation of the epiphysis of the femur may occur, and sometimes the neck. Rarely the lower part of the shaft is fractured. Either condyle may be fractured off or there may be a T fracture, in which case the popliteal artery may be injured. In dislocation, the head may be behind or in front of the acetabulum, impacted hip where the neck of the femur has, in a fall, been driven into the head. In common impacted hip where the neck of the femur has, in a fall, been driven into the head is common in old people. Sometimes, especially in young children, the bone is infected. Osteomyelitis, sarcoma occurs. Most tubercular disease of the hip originates at the upper extremity of the femur. Tuberculosis generally starting in the head and then attacking the capsule and the soft parts of the joint. If neglected, shortening of the leg may result, in which case the bone has to be broken and set at an angle in order to enable the child to walk. Occasionally, a bit of cartilage gets broken off in the knee joint and wedged between the bones so that the joint cannot be straightened. This is dislocation of the semilunar cartilage and necessitates an operation for removal of the piece. The cartilage will eventually be replaced by fibrous tissue, and in a few months the leg will be all right. Dislocation of the knee is rare, though it may occur in any direction. Often the bursae of the joint are irritated, as by kneeling to scrub floors, and bursitis or housemaid's knee results. Fracture of the patella may be caused by muscular traction or by direct violence, and is generally repaired by making an incision and sewing the parts of the bone together. Tumor albus or white swelling in tuberculosis of the knee, and is tumor albus or white swelling is tuberculosis of the knee and is fairly common in children. Specific knee means syphilis of the knee and generally occurs in both knees. The tibia. The tibia or shin bone is next longest to the femur and is on the inner side of the leg. corresponding to the ulna in the arm. The shaft is prismoid and is more slender for the lower quarter, where fracture is consequently more frequent. The anterior border forms the crest or shin and can be felt for its upper two-thirds. The lower extremity, which is smaller than the upper, articulates with the astragalus bone of the ankle with the fibula. Its head or upper extremity is expanded into two lateral tuberosities for articulation with the femur and for muscular attachment, both of which can easily be felt just below the bend of the knee. Their upper surfaces are smooth and concave, with a vertical bifid spine in the middle and a prominent tubercle for the attachment of the semilunar cartilages on either side. On the anterior surface of the head below is a rough eminence or tubercle, which can be felt. The lower part of this is for the attachment of the ligamentum patella, while the upper part, which is smoother, is for the bursa that is placed under the tendon to prevent friction. On the back of the outer tuberosity is a facet for the head of the fibula. At the lower end, there projects downward on the inner side, overhanging the arch of the foot, the internal malleolus, the prominent part of the ankle. It is on a higher level and somewhat farther forward than the external malleolus. The fibula. The fibula is the most slender of all the bones in proportion to its length and is on the outer side of the leg. Its head is small and placed toward the back of the tibia, below the knee joint, from which it is excluded. The head articulates with the external tuberosity and has extending upward from it the styloid process. To it is attached the biceps tendon or outer hamstring. At the lower extremity of the shaft is the external malleolus, which articulates with the astragalus and forms the outer ankle. The only parts of the fibula that can be felt besides the malleolus, which is very prominent, are the head and the lower external surface of the shaft. In fracture of the leg, both bones are usually broken, though either may be broken separately. Pott's fracture is fracture of the lower fibula. It may be caused by stamping hard when stepping on the sidewalk. In rickets, the tibia becomes bowed outward and forward, causing bow leg, a condition which in very young children may be rectified by manipulation. Later on, braces are needed, and after 5 years, the bones have to be broken and set straight. The ankle. The ankle or tarsus has but 7 bones, where the wrist has 8. They are the os calcis or heel bone, which is the largest and the strongest, and forms the tuberosity of the heel. The astragalus, which is next largest and helps to form the ankle joint. The cuboid, the navicular, boat-like, or scaphoid, and the internal, middle, and external cuneiform bones. The astragalus is above and partially in front of the os calcis, to which is attached the tendo Achilles. The cuboid is on the outer side of the foot, in front of the os calcis and behind the metatarsals. It is noticeable in congenital clubfoot, in which condition the tarsal bones may be distorted in shape and misplaced. The navicular or scaphoid is on the inner side of the foot, between the astragalus and the 3 cuneiform bones. The foot. There are 5 metatarsal bones in the foot, corresponding to the 5 metacarpal corresponding to the 5 metacarpals in the hand, and the toes have the same number of phalanges as the fingers, though they are shorter and stronger. The big toe corresponds to the thumb. Fracture of the os calcis and the astragalus is most commonly caused by a fall from a height, while the metatarsals and phalanges are generally broken by something heavy falling upon them. Because of their delicate structure, their distance from the heart, and the differences of temperature to which they are subjected, the tarsal bones are especially liable to become tuberculous, amputation of the foot even becoming necessary at times. In diabetes, there may be a perforating ulcer on the sole of the foot and the bone may become diseased. Muscles of the leg. The greater part of the calf of the leg is formed by the gastrocnemius. The greater part of the calf of the leg is formed by the gastrocnemius, a large bulging muscle which rises from the condyles of the femur and is inserted along with the soleus, whose origin is on the back of the upper fibula, and the plantaris, which comes from the linea aspera into the os calcis by a common tendon, the tendo Achilles, the largest and strongest tendon in the body. Its action is to extend the foot and to rotate it slightly inward. Other extensors of the foot, which also evert it, are the peroneus longus and the peroneus brevis. At the upper and outer part of the leg, the former rising from the outer tuberosity of the tibia and the upper fibula and being inserted into the first metatarsals, and the internal cuneiform, the latter arising from the lower fibula and being inserted into the fifth metatarsal. The foot is flexed, abducted, and rotated inward by means of the tibialis antiquus, which rises from the outer tuberosity and the upper 2/3 of the outer surface of the tibia and is inserted into the internal cuneiform bone. And the foot, and corresponding to the palmar fascia in the hand, is the plantar fascia, the densest of all fibrous membranes. There are also various annular ligaments, and the foot muscles are arranged similarly to those in the hand. The blood supply of the lower extremity. The blood supply of the lower extremity comes from the external iliac artery, a branch of the common iliac, which passes obliquely downward and outward along the border of the psoas muscle to Popart's ligament, where it enters the thigh and becomes the femoral artery. Its only important branches are the deep epigastric, which goes up along the internal abdominal ring, and the deep circumflex iliac, as the femoral artery is passed down the inner side of the thigh to the internal condyle of the femur, being very superficial at Scarpa's triangle, where it can be compressed with the thumb to stop hemorrhage below. If a tourniquet is applied, it should be applied a little lower down. The first and most important branch of the femoral is the Profunda Femoros. About 2/3 of the way to the knee, the artery takes the name popliteo. It lies superficially in the popliteo space back of the knee, but above and below it is covered with the muscles. Its branches supply the knee joint and nearby muscles and are unimportant. At the lower border of the popliteus muscle, a small muscle at the knee, it divides into the anterior and posterior tibial arteries. The course of the former of these may be marked by a line from the inner side of the head of the fibula to midway between the malleoli at the front of the ankle, where it terminates in the dorsalis pedis artery for the back of the foot. By this last, the pulse is sometimes taken, and its pulsation is a guide in determining how high up to amputate in gangrene of the foot. The posterior tibial extends obliquely down the back of the leg to the heel, where it divides into the internal and external plantar arteries, which go to the sole of the foot. Its most important branch is the peroneal. Besides the deep veins accompanying the arteries, there are the superficial veins, the internal or long saphenous on the inner side of the leg and thigh, and the external or short saphenous on the middle of the leg posteriorly and emptying into the popliteal vein. Varicosity often occurs in these veins. Nerves. The nerves of the muscles about the hip are branches of the lumbar nerve. The anterior crural supplies the anterior part of the thigh, the gluteal, the muscles of the same name, and the great sciatic, the large muscles of the back of the thigh. Below the knee, the anterior tibial goes to the tibialis antiquus, and the internal popliteal to the muscles of the calf, while the peroneus muscles are supplied by the musculocutaneous. End of book. Completed this day, Friday, March 4th at 12:38 Pacific Standard Time, 111 years after it was written, the year 2022.